In this segment of the review course, I'm going to cover hyperlipidemia. So some of the basics about cholesterol. Hyperlipidemia is often referred to in patient spaces as high cholesterol. So in the blood, we can have high levels of cholesterol, and particularly the thing that we're monitoring most and paying attention to most is LDL. So that's the important marker. That's something that we assess in labs. And basically, the higher that LDL, the more risk we're at to form cholesterol deposits in the vessels, which can ultimately block off blood flow. And that can be in the form of certainly a heart attack, probably the most common thing you think about as far as high cholesterol goes. But it also can contribute to things like stroke as well, where those vessels are clogged up in the brain. So again, these deposits can kind of build up and then break loose and obviously flow downstream in the blood vessels to smaller blood vessels and clog them or block them. And we can end up with a heart attack and stroke. High cholesterol patients are typically going to be asymptomatic until something bad happens. And so that can sometimes lead to a challenge in treatment because patients generally don't want to take medications for things that they can't feel, or at least it can be challenging to explain that to them, that, we're taking this medication to prevent a future event, not necessarily to make you feel better today. So again, LDL is that primary focus. Historically, it was more based upon risk factors and those type of things. Now we've kind of shifted back in drug selection and aggressiveness based upon the LDL number. There's also triglycerides as a part or component of cholesterol management. Typically, we don't worry about them too much, except for when they get above 500. Then we can bring in other agents like fibrates and niacin and things. So LDL and treatment of LDL is the most common issue here that I'm going to heavily focus on, with the use of statins and other medications to bring down that LDL. Just some other risk factors, some things in primary prevention. So when we talk primary prevention, that's basically, managing some of these factors prior to an event happening, prior to a stroke, prior to a heart attack happening. So we can, bring all these factors in, and we can get a risk calculation for what's your risk. So, the older you are, gender, race, cholesterol levels obviously can play a significant role in that risk. Higher cholesterol, the greater risk you are likely to have an event. Higher blood pressure, same thing. If you have diabetes, if you're a smoker, these all raise your risk for cardiovascular problems. The target goal for high-risk patients, so let's say if you had a patient with, they've had a heart attack in the past, typically what the clinician is going to shoot for is a LDL goal of less than 70. And where this comes into play is drug selection and the dose that we try to get to. Okay, so first step in treating elevated LDL and trying to get that down for clinicians is a high-intensity statin. So that would be like atorvastatin and rosuvastatin. And those are the most common statins that you'll see utilized. They're generally cheap. They get the LDL down, or at least we can do that with higher dosages. We can have substantial drops in LDL, which sometimes we need to do. We do have other add-on medications. Ezetimibe is probably the most common one there. I'll get into that, and PCSK9 inhibitors, as well as bempedoic acid is another one as well. I've spent over a decade teaching pharmacology, and I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the MedEd 101 Nursing Pharmacology Review course at meded101.com/nurse. In addition, you'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides which you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed to teach you things that matter on the test and in practice. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the Meded 101 Nursing Pharmacology Review course. All right, so I wanted to just point this out, why you see atorvastatin and rosuvastatin used so much in practice. These are the only two medications that can lower LDL by 50% or greater. Okay, and we do this at higher dosages. Rosuvastatin 20 to 40 milligrams and atorvastatin 40 to 80. And I just wanted to point this out. Not that you have to memorize this or anything, but that's why you see atorvastatin and rosuvastatin used most often. Okay, so if you had a patient where we just needed to reduce the LDL by a little bit, well, why not just use a low dose of the high intensity? That way you don't have to change drugs either if we need more LDL lowering. So, just wanted to kind of give you that outline and rundown there. All right, so statins. Let's dig into this. Brand names: Lipitor, Crestor, Zocor, Pravachol, Mevacor. Those are definitely the 5 most commonly used agents. Mechanistically, they inhibit HMG-CoA reductase, and that is the rate-limiting step in the production of cholesterol. So remember the HMG-CoA reductase inhibitor. That's a good way to remember these medications if you need to know that mechanism on an exam. Probably the biggest thing patients will bring up is muscle pain, muscle soreness. Either, they have it themselves, they know somebody who've had it, and it's often a significant reluctance for them to take statins. Okay, so that's an important thing to note. And if you have somebody that started on a statin, and they're, reporting an increase in achiness and soreness and those type of things, and it's not attributable to something else, you definitely need to take a look at the statin and discuss that with the attending provider there. So important to pay attention to that. Now, there's a very small subset of myopathy type patients, muscle soreness, that can progress to rhabdomyolysis. And in this situation, this is actually causing some muscle breakdown. All right. And we can check a lab, CPK, and see if this is elevated. So that's a good one to remember there as well. But rhabdomyolysis can be is rare, but it can be very, very severe. We can run into a risk of acute renal failure because of this. Okay. One drug interaction I'll mention with statins are the fibrates. These can increase the risk of rhabdomyolysis. So a medication like gemfibrozol, for example. One other thing I will mention is about timing and administration. A few of these, typically it doesn't matter when you give it. Rosuvastatin is a good example there. However, one like simvastatin does have a little bit shorter half-life, and our body tends to produce more cholesterol at night. And so that is the reason why you see some of the statins preferred to be given at night. So I just wanted to point that out and mention that's why you may see that. With that said, if I've got a patient that forgets to take medications at night, I would definitely encourage them, to take it in the morning if they have to. Okay, so I'd rather have them get it, than try to schedule it at night. And now they're forgetting to take it at night. So, but like I said, with that said, mostly the rosuvastatin, atorvastatin, I'm not too picky on the time of day that either of those two are given. But keep in mind that some of those statins need to be given, or should ideally be given at night. That's when they're going to work their best. A few clinical practice pearls. Again, rosuvastatin, atorvastatin, highest intensity. They'll bring LDL down the most. Generally avoid simvastatin. We've got a lot of interactions with that. And grapefruit juice, in addition to amlodipine, amiodarone, diltiazem, it can increase the concentrations and increase the risk for toxicity with simvastatin. So that's a good one to remember there for sure. Atorvastatin, I will say, does have some CYP3A4 drug interaction potential as well. Rosuvastatin does tend to avoid that a little bit more. So if that's an issue with some of the meds that the patient is on, that rosuvastatin tends to do a little bit better. And then lovastatin is CYP3A4 as well, so some interactions there too. All right, so other medications, ezetimibe, brand name Zetia. We've got PCSK9 inhibitors and bempedoic acid. These may be added to a statin to help bring that target LDL down, or get to the goal that we're trying to get to. Also important, we can try a different statin. So if somebody, has a little bit of muscle soreness on one statin, we may consider trying a different one. So that is okay. My encouragement for you is if you've got a patient reporting that they're having issues with a statin and they're not going to take that medication again, do your best to document what the reaction was, how severe it is, and all that good stuff, because somebody down the line is going to want to know that. And okay, can we try another statin or not? It's like, okay, well, they had a life-threatening reaction to a statin. It's like, okay, maybe I'm not going to try a statin. Maybe I'll do one of these other options. But if it was just like, they had some, mild arm pain or something, it's like that wasn't that severe. You might try a different statin and see if that's tolerable and or potentially a lower dose. All right, so those other medications, bempedoic acid, this is what's called an adenosine triphosphate citrate lyase inhibitor, or an ACL inhibitor, oftentimes an add-on therapy. One important point to note about this one, patients with gout, it can cause elevations in uric acid. The other thing I will mention is tendon rupture risk has been reported as well. Quinolone antibiotics like ciprofloxacin and levofloxacin, that's a notorious adverse effect of those too. So that combination may even exacerbate that risk even further. Zetia or ezetimibe, this actually inhibits gut absorption of cholesterol, okay, via the MPC1L1 transporter in the gut. And this is often a good add-on to statin therapy to, try to get that LDL down a little bit further if we're not hitting our goal. Generally pretty well tolerated, maybe just a little GI upset, and, possibly adding on to that myopathy risk in combination with statins. PCSK9 inhibitors, these are actually humanized monoclonal antibodies. They are injections, so that is a big downside, and it's every 2 to 4 weeks, and they are very, very expensive. So typically PCSK9 inhibitors, like Praluent and Repatha, they're only going to be used in severe cardiovascular disease. So, patients that have had, multiple heart attacks and, or multiple strokes or something like that, okay? But what this does, so PCSK9 destroys LDL receptors in the liver, and by inhibiting this, it allows LDL receptors to do their job and to remove that LDL in the bloodstream, basically. One potential advantage, we don't have the muscle toxicity compared to statins, so if somebody's failed statins, they always have myopathy, for example. This may be a potential alternative option. But again, the downsides, patients certainly don't love injections all the time. And adverse effect profile, we can have some injection site reactions, as well as fatigue has been reported. And then triglycerides, I'll mention the fibrates. These activate lipoprotein lipase. This ultimately leads to the breaking down of fat and triglyceride-rich particles. So fibrates, if you see those prescribed, we're focusing more so on triglycerides. Recall that an elevation in triglycerides, if it gets way too high, a common patient population is those with alcohol abuse problems. The risk with elevated triglycerides is pancreatitis. Okay, so if those TGs or triglycerides get too high, we can increase the risk for pancreatitis. Gemfibrozole tends to have a little bit higher risk of rhabdomyolysis, and particularly in combination with statins. Fenofibrate is probably what I see used most often because of a little bit lower risk of that rhabdomyolysis and muscle soreness type of adverse effects. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the Meded 101 Nursing Pharmacology Review course.